Hello and welcome to the channel. I'm going to be looking at the use of nicotinamide in dermatology, specifically with regards to its use in preventing skin cancers. I'm doing this because the research on nicotinamide grabs a lot of attention. They lead to media outlets sensationally declaring its benefits, but I'm not sure these papers mean what we're being told. So I'm going to go through the science in more detail. But I'm not here to give medical advice. If you're a patient, you should discuss with your own doctor whether you should be taking nicotinamide. This channel is to review papers and discuss evidence, not give medical advice on your situation. This was one of the recent papers published at the end of last year in one of the top-ranked dermatology journals. The headline finding, 14% reduction in skin cancer risk, was repeated again and again in the media. You'll note the date it was published online first, on September 17th, 2025. These are some of the examples of the media picking up on the study. This study got worldwide attention. Note the dates of some of the media releases. It's identical, September 17th, 2025. I'm so impressed these journalists would know the paper had just been published, much less review and digest the paper and write up a news article on the same day the study is published online. That's impressive work. One might think they were forewarned it was going to be released and then wrote the news articles to help promote the paper. Who knows, right? Anyway, back to the paper. Here's the abstract. The opening line. Nicotinamide supplementation has been studied as a chemopreventative medication for reducing skin cancer risks, but large-scale data are limited. Now, I don't know about you, but to me, the way it's phrased as an opening statement would imply that although there have been previous studies, those studies were somehow lesser in quality, that this study is going to be better because it's going to give us large-scale data. But if you've been watching some of the other videos on this channel, you know that larger studies do not immediately mean the data is going to be better. So immediately I get red flag vibes. Either the authors do not know what makes good data, or they do and make statements like this anyway to convince you the data you're about to be shown is good because it's large scale. Moving along, this study is a retrospective cohort study using data from over 30,000 US veterans. They match veterans exposed to nicotinamide with controls and measure the development of skin cancers. That's pretty much the study. Now, the original study that was done to look at this issue was a randomized control trial. So this study, being an observational retrospective cohort study, is meant to be some kind of advance. Why would that be? Let's look more carefully then. In the methodology, something jumps out at you. Who is exposed to nicotinamide? In a randomized trial, the exposed group is given the medication, the control group is not. In this cohort study, the exposed group are those patients who filled their prescription for nicotinamide. It's a subtle but highly relevant difference. It's possible controls were prescribed nicotinamide too, but for whatever reason did not fill their prescriptions. Because we know patients who fill their prescriptions are fundamentally different to those that are less compliant. Maybe they care more about their health. Maybe they can afford to pay for medicines, so they come from a higher socioeconomic group, which we know affects health outcomes. Maybe they worry more about skin cancers, so they fill their prescriptions because they've been told it helps reduce skin cancers. But if they worry more about skin cancers, maybe they spend less time outside. Maybe they use more sunscreen. These unknown confounders can't be controlled or matched for in the study. It's a form of selection bias comparing people who fill their prescriptions with those who do not, a type of systematic error that can't be overcome by a large sample size. I'll come back to the significance of the selection bias in a moment. For now, I'm going to highlight the second major issue that jumped out at me. Here's the headline finding in the abstract: a 14% reduction in skin cancer risk. But in other parts of the paper, the wording changes in a subtle way. Here, it's a 14% reduction in the rate of new skin cancers. And where does the 14% figure come from? right here, the calculated hazard ratio of 0.86. Subtract that from 1 and you get 14%. 14% risk reduction, 14% rate reduction, risk, rate, oh, it's all the same, isn't it? Well, unfortunately, it's not. Here's a key point I want you to take away from this video. Hazard ratios are not risk ratios. They are mathematically different concepts. Hazard ratios are not intuitive. They measure the relative rate of experiencing an event at an instantaneous time point, whereas relative risk expresses the cumulative risk over a fixed period of time. It is complete bonkers to use the two concepts interchangeably. In other words, the measured hazard ratio of 0.86, the actual results and main finding in this study, does not mean that there is a 14% reduction in the risk of skin cancers. Before you even consider whether there were any issues in the study design, the actual results don't mean what the headlines are suggesting, that nicotinamide will reduce your risk of skin cancers by 14%. The results, even before accounting for any bias, showed a 14% reduction in the rate of skin cancers, but not the risk of skin cancers. That might sound awfully the same, but I'm going to show you how different these concepts are. Epidemiologists have been warning about this issue in medical papers for many years. Here's one warning, quote, "In practical terms, 1 minus the hazard ratio should not be interpreted as a risk reduction." Here's another warning, quote, "Perhaps due to a lack of understanding, authors continue to interpret hazard ratio as a relative risk. Such an interpretation is inappropriate and can be misleading." For me, it's difficult to have confidence the survival analysis modeling done in this paper has been done with any scientific rigor. If whoever was doing the stats in this paper is confusing hazard ratios with relative risk, it's like an aircraft engineer confusing acceleration and velocity. I wouldn't get in that airplane. This table is from the paper I just quoted. I'm sorry the table looks so unfriendly and you might have to pause the video to see what's going on, but the key point is this. For any given hazard ratio, the actual relative risk can vary substantially, depending on the baseline risk of the control group. For example, if you calculate a hazard ratio of 0.5, then the risk reduction could be anywhere between 0.51 and 0.76. You can see that when hazard ratios are less than 1, the calculated hazard ratio always overestimates the relative risk reduction, and the magnitude of the overestimation depends on the baseline risk of events in the control group. If we come back to our study, we don't know what the baseline risk of events in the control group is because the study design doesn't allow for such a calculation. But we can see that the number of events in the control group is quite high early in the study, so events are not rare. And we would not expect that a skin cancer in a group of older US veterans to be a rare event. So we can reasonably say that the baseline risk of an event in the control group is quite common. So we know the hazard ratio overestimates the relative risk reduction when it's less than 1, and we know that events are not rare. So what I've done here is I've asked Google to plot the relative risk against different baseline risks for a given hazard ratio of 0.86, which is what was found in the study. And if we take the example of a relatively common rate of, say, 0.8 baseline risk in the control group, now the real relative risk is about 0.94. In other words, the relative risk reduction would be about 6%, not 14% as the authors claim. Now, as I said, we don't know what the baseline risk is, but if it is common as we suspect, say between 0.5 and 0.9, then the actual relative risk reduction from the study would be somewhere between 4 and 10%, not 14% as the authors claim. And that's before we consider the selection bias I was talking about at the start of the video. When you factor that in, perhaps the difference is in the order of 5%. Now, I don't know if 5% would still make the differences statistically significant, but in my opinion, it wouldn't be clinically significant, even if true. The claim of a 14% relative risk reduction in skin cancer risk, based on the hazard ratio of 0.86 calculated in this study, has no scientific basis behind it. It's a complete misunderstanding of hazard ratios and an overestimate of the real relative risk reduction. Now that you know hazard ratios are not risk ratios, you're going to see it being done all the time in medical research. That's why there are articles from epidemiologists specifically warning for it not to be done. Here's one of my favorite parts of the paper towards the end. Quote, "We are currently in the process of developing a trial to overcome many of the limitations of observational cohorts. Despite propensity score matching, there were likely unmeasured confounders that would be better accounted for in a prospective trial." Well, if there are many limitations of observational cohorts, why do this study then and make big claims in the media about what the study shows? And if prospective trials better account for unmeasured confounders, why don't we, I don't know, just look at the prospective trial that was already done before? You know, the randomized control trial that was done 10 years ago. What's the point of this study if the authors themselves think that prospective randomized trials are better when they've already been done? So let's look at those randomized trials. This is an old study, 10 years old, but I'm going to talk about it for two reasons. Firstly, because it represents the best study ever conducted on this issue. It's a randomized placebo-controlled trial. The data is the best we have. It doesn't get better than this in medical studies. It seems regressive to me that after all these years, we are now doing observational cohort studies on this issue, as though somehow that will be an advance. If we want better data, we're going to have to do better randomized trials, not do a bunch of observational studies. And the second reason, when I say it's the best study we have, I don't mean everyone should be on nicotinamide. As I'm going to discuss, there are a lot of fine print that is missing from discussions on nicotinamide. People just read the abstract and take away the headline, a 23% reduction in skin cancers. The first point I'll make about the results is the statistical significance test with p equals 0.02. By definition, it's statistically significant, but you would be generous to call that strong evidence. P equals 0.02 is the kind of result where a few patients on either side of the equation would have made the results non-significant. So significant, but weakly so. The second thing is to look at the confidence interval. The results suggest the true reduction in skin cancer risk is anywhere between 4 and 38%. Now, I've said I don't personally think a 5% reduction in risk is clinically meaningful. A 38% reduction would be really meaningful though. So the results suggest there is a weak level of evidence that the reduction in skin cancer risk is anywhere from clinically insignificant to highly important. Weak evidence of a big range. I would argue that's the fairest way to interpret the headline findings. The next thing I want to highlight, what kind of skin cancers are we actually reducing? When you look at the data, it's the less aggressive ones that are mostly being reduced. The superficial BCCs and the in situ SCCs, especially the superficial BCCs. The reduction in superficial BCCs contributes the bulk of reduction in skin cancers, almost halved by nicotinamide. I would argue if not for the large reduction in this group, it's unlikely the statistical significance test would have been made, because they did the significance test based on the total number of skin cancers. So it's the large reduction in these types of skin cancers that contributed a lot to the difference in skin cancer counts. And even then, it only just made statistical significance. Now, if that's true, I want you to consider what patients care about when they think about skin cancers, when they go and have skin checks. Because that leads to the question, what do they hear when we say to them, this vitamin will reduce your risk of skin cancers by 20%? In my experience, this is what patients care about. They care about dying from a skin cancer. They care about losing their nose, their ears, getting large scars on their face from having skin cancers cut out. But superficial BCCs and in situ SCCs generally do not cause these issues. I don't know the patient who was really upset because I curated one more superficial BCC from their back or leg. So the point is this: will nicotinamide result in a clinically meaningful benefit? Will it result in less death from skin cancers? Will it result in 20% less surgery on the nose or ears? That's the kind of study I'd like to see, one with clinically meaningful hard endpoints that really matter to a patient. Unfortunately, you're not going to see that in the literature. Studies simply focus on the number of skin cancers. Does a patient take nicotinamide because they're worried about one more superficial BCC being curated from their back? Or do they take it hoping they won't lose their nose? And if they're taking it because they don't want to lose their nose, are they being misled? When we tell a patient taking this vitamin will reduce their risk of skin cancers by 20%, what do they actually hear or are hoping for? Let's focus more on this figure you hear, 20% less risk of skin cancers. How many skin cancers were actually prevented? If we look at the difference between the placebo and nicotinamide groups here, we see about 0.6 skin cancers per person was prevented. If you've ever heard about the concept of a number needed to treat, you know we get this from the absolute risk reduction numbers. I need to emphasize this kind of number needed to treat is talking about multiple events in patients. So when I'm talking number needed to treat here, I'm talking about number of skin cancers in patients, not number of patients with skin cancers. Number of skin cancers in patients, not number of patients with skin cancers. 0.6 skin cancers prevented per patient over the study period of 1 year. That works out to be 2 skin cancers prevented out of every 3 patients taking nicotinamide for a year, based on the baseline risk of patients in the study. Now, the baseline risk of the study was 2.4 skin cancers per patient. So that means for these 3 patients taking nicotinamide over the year, they would have got on average 7 skin cancers. But now they only get 5 skin cancers. 5 rather than 7 in the 3 patients. That's what the study data actually shows. Maybe one patient got lucky and had 2 skin cancers prevented, but that means the other 2 patients would have received no benefit from taking it. And remember, the 2 skin cancers you're preventing over the year in these 3 patients, more likely than not, they were superficial BCCs or in situ SCCs. What about patients with different baseline risks? Another way to look at a 23% risk reduction is to say, if you have a patient who on average gets 5 skin cancers a year, now they might only get 4. That's 1 less skin cancer a year for someone who normally gets 5. But if they are low risk and get 1 skin cancer every 5 years, they would be taking a vitamin twice a day for 5 years to prevent that 1 skin cancer. Now, if that 1 less procedure is to save your nose, you might argue that's worth it. But if it's to stop 1 curette on your back after 5 years of taking a vitamin every day, is it all worth it? Only the patient in consultation with their doctor can decide. I'm just trying to present different ways of looking at the same data set, ways that I just don't hear discussed enough when I hear dermatologists talking about nicotinamide. Talking about patients with different baseline risks, remember me saying that our best, most reliable data comes from randomized control trials? There is another randomized trial on nicotinamide and skin cancers, but this time it was done in immunosuppressed patients, which, as you probably know, are a group at high risk of skin cancers. This was published a few years ago. This one found no difference between the groups. About 200 skin cancers in the nicotinamide group, about 200 skin cancers in the control group after a year. A lot's been said already about this study, and I don't want to rehash too much of what you easily get elsewhere. It had trouble recruiting patients, it may have been underpowered, Perhaps the mechanism of action of nicotinamide is affected by immunosuppression. These are reasonable explanations for why no difference was detected. But if you want to be an open-minded scientist about it, you'd have to entertain the possibility that this is a true negative, and the other randomized trial that was originally done that just reached statistical significance could have been a false positive. Because when we try and explain the results of this study away and just say it was underpowered, they did not recruit enough patients, that's why a difference was not detected, what exactly does that mean? Remember, we're talking about number of skin cancers in patients, not number of patients with skin cancers. It's different to a study on heart attacks where only a small proportion of the hypertensive patients you're following up get the event a heart attack. In this type of study, most patients get the event a skin cancer, and in most cases, they get more than one event. It's the difference in number of skin cancers that matter most, not how many patients you recruited. Although obviously, the more you recruit, the more skin cancer events there are. But when you're up to hundreds of skin cancer events in a study, and you're not even picking up a slight signal, then it must mean that even if a difference really exists, then that difference must be small. Because if nicotinamide made a big difference, it would have been picked up easily. That's how sample size calculation works. How big a difference in event rate between the groups there really is. My own view of nicotinamide in 2026 is that it probably reduces the risk of skin cancers by a small amount. I'm not sure the small amount and the type of skin cancer that's probably being reduced, and therefore the amount of benefit, makes a huge difference for most patients' lives. I hope there will be more randomized trials showing hard clinical endpoints like death or major head and neck surgery that would convince me that it's a great chemopreventative agent. I'm not hopeful though. If we look at the closest other agent we have, acitretin, we've only had 3 randomized trials ever looking at acitretin and skin cancers, the last of which was in 2012, and none of them ever had hard clinical endpoints. It's always just number of skin cancers. You've been watching Derm EBN. Thanks for making it this far. Do you have a different view of nicotinamide? If so, please share your thoughts and make a comment. Hit the like button if you've enjoyed watching and subscribe if you want to be notified when a new video is released. Thanks again.